Good morning to all. Welcome to today's student CPC and happy Ganesh Chaturthi for everyone. So we will be discussing two cases, and first will be discussed by Dr. Ayush Singh. I invite him on podium for first presentation.
Good morning, everyone. I'm Dr. Ayush. Today I'm going to discuss the clinical part of student CPC. Demographic: Miss SK, 26-year-old female, resident of Patiala, admitted on 29th of April in under CHMO unit in HHDU. Duration of hospital stay being 3 days and date of demise being 1st of May. Background history: patient had been complaining of generalized weakness and fatigue since 1 month, which was gradually progressive and was evaluated in outside hospital in Nahan, where CPC showed pancytopenia and patient underwent PBF examination on 16th of April, which showed atypical cells with prominent nucleoli. History of presenting illness: patient presented to emergency OPD on 28th of April with periorbital ecchymosis, PTK, and right-sided headache associated with visual blooding. There is no history of fever, no history of cough, no history of blood or platelet transfusion, no history of arthralgia, no history of dysuria, pyuria, or pedal edema. Other history: past history not significant. Personal history: patient had been complaining of loss of appetite and loss of weight, which was undocumented. Family history not significant. On general physical examination, patient was drowsy and arousable on loud commands. Her vitals were stable. Her GCS was E3V5M6 with bilateral periorbital ecchymosis. Fundus examination showing retinal hemorrhage, oral cavity normal, and she had significant pallor with no teres, clubbing, cyanosis, lymphadenopathy, or pedal edema. On systemic examination, her respiratory system, CVS and per abdominal examination was within normal range, within normal limit. On CNS examination, patient was drowsy with GCS of E3V5M6, power 5/5 in all limbs with no focal neurological deficit and normal sensory examination. Investigation: patient had anemia of 7.2 with a platelet count of 17,000 at presentation to EMOPD with a leukocyte count of 17,000. PBF examination was done, which showed 88% blast cell, and some of the blasts also showed erodes. Possibility acute myeloid leukemia, though APML cannot be ruled out. Her renal function and liver function were within normal range. Flow cytometry was also done, which was consistent with APML. Bone marrow was also done, which showed PML-RA fusion gene positive, consistent with APML classical type. Other workup: ultrasound whole abdomen showed no significant abnormality. ABG parameters were within normal range. Her D-dimer was elevated up to 9,878 with a APTT of 28 and PT of 18. Her ECG showed sinus tachycardia. Now I would like to call Dr. Gopika to discuss the radiology of the patient.
Good morning, everybody. I'll be presenting the X-rays and the CDs I was provided with. I have two serial X-rays that happened on 29th and 30th of April. And the X-ray of 29 was within normal limits, and the X-ray of 30th show a few opacities in the left upper zone. And moving to the NCCT. I was provided with two CTs of the head. One was NCCT that happened on 29th, and the other one was CECT that happened on 30th. The NCCT of 29th April was within normal limits, within the limits of non-contrast studies. And the NCCT that happened on 30th, followed by CECT. The NCCT, the only positive finding in NCCT was a linear hyperdensity that we can see in the right tentorium. And on contrast studies, we can see that the dural venous sinuses are congested. So this might indicate, this might be a subtle sign of venous thrombosis, but we should have had an MRI studies with MR venography for confirmation. Thank you.
Course and management: patient with complaint of generalized weakness and periorbital ecchymosis, PBS suggestive of APML, and patient was subsequently started on all-trans retinoic acid and arsenic trioxide on 28th of April with component support. Capsule hydroxyurea at a dose of 1 gram oral TDS was also added for cytodeduction. On 29th of April at 2 p.m., patient became drowsy and NCCT head was done, which was normal, and patient was subsequently shifted to HHDU. Patient had 2 episodes of seizure at 9:51 p.m. followed by decerebrate posturing, and was given loading dose of 5 midazolam and patient underwent intubation in order to protect her airway. Repeat CT scan was also done, which showed no evidence of bleed. Patient started complaining of fever at 11 p.m. and was started on IV Magnex at dose of 2 gram every 8 hourly and vancomycin at dose of 1 gram BD. Her sensorium did not improve despite antiepileptics and increased ICP management. Blood and electrolytes were within normal range. CSF was not possible as patient had significant thrombocytopenia and patient was subsequently planned for CMRI brain. Patient continued to have fever spikes, resulting in decrease in urine output and increased ventilatory requirement. And patient subsequently developed shock, requiring inotropes, and had a cardiac arrest at 9 a.m. and was given CPR according to ACLS protocol and was declared at 9:59 a.m. Database. On history, patient had generalized weakness and fatigue with periorbital ecchymosis, PET-EK, and blurring of vision. On examination, patient was drowsy. Patient had significant pallor. Fundus examination showing retinal hemorrhage. On investigation, patient had bicytopenia with leukocytosis, PBS suggestive of 88% blast, and bone marrow biopsy suggesting PML RARA fusion gene positive. So today we are going to discuss about the basic disease, the current presentation, and the pre-terminal event. Patient with a history of generalized weakness, periorbital ecchymosis, and a rapid downhill course with PVS suggestive of bicytopenia and Faggot cell, and flow cytometry suggestive of APML, and bone marrow biopsy suggestive of APML. So we are basically dealing with a case of acute promyelocytic leukemia, classical type. Based on SANS and revised SANS criteria, our patient had a WBC count of 21,000. Our patient belongs to a high risk and therefore also has a high risk of early death. Various complications can be seen in a patient with acute promyelocytic leukemia, like differentiation syndrome, febrile neutropenia, neurological complication, sepsis, DIC, tumor lysis syndrome, and ocular complication like retinal hemorrhage and optic nerve ischemia. Neurological complication in acute promyelocytic leukemia can be leukemia-related or treatment-related. Leukemia-related complication can be due to direct involvement, which can be leptomeningeal dissemination, parenchymal infiltration, and vascular sluggish due to hyperleukocytosis. Indirect complication can be due to hemorrhage, DIC, and sinus venous thrombosis. Treatment-related complication can be hemorrhage, infection, lumbar puncture-related encephalopathy, subdural hematoma, and post-LP hematoma. Current presentation. Patient was altered in form as she was drowsy and also had multiple episodes of seizure. So various possibilities are cerebral venous thrombosis. As patient had multiple episodes of seizures, patient is a high risk APML case. And at presentation, patient had headache associated with blurring of vision, and radiology was also suggestive of CVT. Intracranial bleed, as patient had thrombocytopenia and headache, but there was no evidence on imaging, and patient did not have any focal neurological deficit. CNS infiltration, patient had leukocytosis, but CNS infiltration is usually seen at a leukocyte count more than 50,000. Infection, patient did not have any source of infection at the time of presentation. Patient with a platelet count of 21,000, with a D-dimer of 9,878, with a PT of 18 seconds and a fibrinogen level of 1.92, with a ISTH score of 6. So DIC is also a probability in our patient. APML patients are at increased risk of DIC, which subsequently lead to increased risk of bleeding and thrombosis. And CNS and the lung are the most common site of hemorrhage as well as thrombosis in APML patients. Management of DIC involves treating the underlying condition, which is the most important part. And if patient is actively bleeding, then we have to give platelet, plasma and factor concentrate to maintain PT less than 3 seconds. Vitamin K should be supplemented if patient is suspected of vitamin K deficiency. If there is no major bleeding, then we have to give prophylactic low molecular weight heparin. And if patient has overt thromboembolism, then we have to treat the patient with therapeutic anticoagulation. In APML, due to DIC, patients are at increased risk of cerebral venous thrombosis. Cerebral venous thrombosis is a rare complication of APML, and it is usually present later in the course of the disease. And 30% of the CVT patient can present with intracerebral hemorrhage, and treatment generally involves heparin, low oral anticoagulant, and thrombolysis. CNS involvement, sequelae events, patient had anemia and DIC, which ultimately lead to vascular thrombosis and which can further progress to terminal intracranial bleeds. These are the thick case report related to CVT as an initial presentation in patient with APML in literature. First case report is in 1988, where an 11-year-old female presented with increased intracranial hypertension and was managed with IV UFH, but patient subsequently progressed to coma and death. A 12-year-old female presenting with increased intracranial hypertension and had CVT in superior sagittal sinus and straight sinus and was managed with IV UFH and was subsequently discharged, but patient was again readmitted with cerebral hemorrhage and underwent unsuccessful interventional thrombectomy. Third patient is a 33-year-old male presenting with increased intracranial hypertension, managed with subcutaneous low molecular weight heparin, and had a good neurological evolution. This is a data from a PGI center. It is a single-center retrospective analysis. Total of 206 patients were included in this study, and the majority of the patients were intermediate risk, followed by high risk. And patients presenting with bleed at the time of the presentation amount to 82%, with intracranial bleed seen in about 8% of the patient. And thrombosis was seen in about 3% of the cases. And early death was within 7 days was seen in about 25 patients, and it was mostly due to disease related, which was seen in about 17 of the patients. And 3 patients died due to infection too. Pre-terminal event, patient with acute promyelocytic leukemia. Patient started having new onset fever with increased ventilator requirement and chest X-ray showing infiltrate in left upper zone, which lead to type 1 respiratory failure. Patient subsequently developed sepsis, resulting in refractory septic shock. Final diagnosis, acute myelocytic leukemia with leukocytosis and DIC, query cerebral venous thrombosis with intracranial hypertension, query cerebral herniation, possibility of hospital-acquired pneumonia, query bacteria. Cause of death being refractory septic shock and type 1 respiratory failure. Thank you.
Good morning, everyone. I'll be presenting the autopsy findings for this case. So a complete autopsy was performed for this 26-year-old female. The prosectors noted that the patient was well built and petechial hemorrhages and ecchymotic patches were noted over the entire body. They also noted that there was 60 ml of pericardial effusion, 160 ml of bilateral pleural effusion, whereas the peritoneal cavities were within normal limits. So starting with the antemortem hematological evaluation of the patient, the peripheral blood showed a total leukocyte count of around 15,000 per microliter, and there was a preponderance of abnormal promyelocytes to the tune of 90%. Now these cells in the peripheral blood, they showed high NC ratio with indented and cleaved nuclei. There was opened up chromatin, inconspicuous 1 to 2 nucleoli, and granular cytoplasm. Many of the cells also showed the presence of multiple stout or rods conforming to the morphology of phago cells, and these were highlighted on MPO staining. So a bone marrow aspirate was performed, and the marrow was found to be particulate and hypercellular with a depletion of the normal hematopoietic elements, and it was largely replaced by these abnormal promyelocytes which show the presence of multiple or rods within the cytoplasm. So on flow cytometry, these cells, they are highlighted here in red, and we can see that there is increased forward scatter and side scatter. They were positive for CD45 and negative for HLA-DR and CD34. So they showed positive expression of a host of myeloid markers. They were homogeneously positive for CD33 and showed heterogeneous positive expression of CD117, CD13 and MPO. They were negative for B cell and T cell markers, thereby ruling out a lymphoid lineage. The bone marrow biopsy was also hypercellular and showed replacement by sheets of abnormal granulocytic precursors. And molecular analysis turned out to be positive for the PML-RARA fusion gene. Therefore, a final diagnosis of acute promyelocytic leukemia classical type was rendered for this patient. So the patient was started on therapy for ATRA, following which she succumbed to her illness, and a complete autopsy was performed. Now, the post-mortem bone marrow biopsy showed hypercellular marrow spaces. There was a depletion of fat spaces, and largely the normal hematopoietic elements were depleted. A few preserved megakaryocytes were noted. However, largely the marrow is replaced by abnormal promyelocytes, which were highlighted on the immunostain for MPO, thereby confirming the diagnosis of APML. So firstly, we'll be discussing the complications of the disease. This is an organ complex comprising of bilateral kidneys, ureters, urinary bladder, and part of abdominal aorta. The capsule of the kidney was easily stripped off and showed multiple pinpoint hemorrhages, imparting a flea-bitten appearance to the kidney. So the cut surface shows distinct corticomedullary junction. However, again, there are multiple tiny pinpoint hemorrhages and hemorrhage within the right pelvic calcaneal system. So at a low power view, we can appreciate that the glomeruli are diffusely involved by the disease process and they appear to be congested. The tubules show isometric vacuolation. And a high power view shows that the congested appearance is due to the presence of fibrin thrombi within the dilated capillary loops, as well as within the afferent and the efferent arterioles. There is also evidence of mesangiolysis because of dissolution of the mesangial matrix and cells. which occurs secondary to acute thrombotic microangiopathy. These fibrin thrombi are confirmed on Marsh's scarlet blue and can be seen extending out into the afferent arteriole as well. On Marsh's scarlet blue, again, here we can see that there is evidence of leukostasis within the afferent arteriole, and there is infiltration of the RBCs into the wall of the afferent arteriole secondary to endothelial injury, which also occurs as a part of acute thrombotic microangiopathy. Now, the fibrin thrombi are seen on the PS and the Mason's trichrome stain. However, there is no evidence of any proliferative or segmental lesions or any interstitial fibrosis on the Mason's trichrome stain. Coming to the tubular compartment, there is simplification of the lining epithelium and mild interstitial edema accounting for acute tubular injury. The hemorrhage within the right renal pelvic calcilial system was confirmed microscopically, and additionally there is also a leukemic infiltrate noted in the right renal sinus fat. Therefore, summarizing the findings in the kidneys, there is acute thrombotic microangiopathy with acute tubular injury, leukostasis with leukemic infiltrate in the right renal sinus fat, and right intrapelvic hemorrhage. The lungs weighed 980 grams, and there was diffuse hemorrhagic discoloration, especially centered on the lower lobes. Along with that, the tracheobronchial tree also showed multiple areas of congestion and mucosal erosions. The cut surface of the lungs was quite consolidated on palpation and showed diffuse areas of fresh hemorrhage involving all the lobes, but primarily centered on the lower lobes. And multiple tiny fibrin thrombi were also noted. So microscopically, we can see that the alveolar septa are expanded by these dilated capillary channels, which are filled with leukemic cells highlighted on the myeloperoxidase immunostain. The leukemic infiltrate was also noted in the subpleural space. Evidence of leukostasis was also noted in the larger pulmonary arteries, again highlighted on the immunostain for myeloperoxidase. There were diffuse pulmonary hemorrhage along with the presence of pulmonary edema. And out of multiple sections examined, only a few tiny foci showed hyaline membranes, which were beautifully highlighted on PS. However, no evidence of any fungal profiles were seen. Some fresh fibrin thrombi were also noted within the pulmonary arteries, again highlighted on Marsh's scarlet blue. Sections from the congested parts of the tracheobronchial tree showed denudation of the lining epithelium with submucosal hemorrhage, and all the tiny capillaries and arterioles in the submucosal space showed presence of fresh fibrin thrombi. A few hilar lymph nodes were also sampled, and they showed diffuse effacement of nodal architecture with leukemic cells, which are again highlighted on MPO. Therefore, summarizing the findings in the lungs, there is leukemic infiltration in the lungs and hilar lymph nodes, leukostasis, diffuse pulmonary hemorrhage with focal diffuse alveolar damage, pulmonary thromboembolism, and ischemic erosions in the tracheobronchial tree. So coming on to the brain, the dura showed a congested and engorged superior sagittal sinus with blood clots on the internal aspect. And the gross examination of the brain showed presence of subarachnoid hemorrhage in the paramedian areas measuring around 6 into 5 centimeters. This hemorrhage was extending into the cerebellar tonsils, especially on the right side, measuring around 4 into 2 centimeters. The gyri were edematous and engorged, and the sulci were narrowed, and there was evidence of uncal notching and tonsillar herniation. The outer aspect of the brain again shows multiple tiny petechial hemorrhages all over the brain, but especially centered around the frontal and the occipital cortex. So multiple slices were examined, and they showed tiny petechial hemorrhages all over the cortical ribbon, especially at the junction of the gray matter and the white matter, but also in the corpus callosum and the bilateral basal ganglia. An area of dusky discoloration was also noted in the left middle temporal gyrus, measuring around 2 into 1 centimeter. So So the subarachnoid hemorrhage is confirmed microscopically along with the presence of multiple perivascular hemorrhagic areas extending deep into the cerebral parenchyma. And at the junction of the gray matter and the white matter, we can see multiple foci of these perivascular leukemic infiltrates with surrounding pale areas. Now, at a hyper view, we can see that these are admixed with fibrin, which can be appreciated on Marshall scarlet blue. And the surrounding pale areas are indicative of myelin loss, which can be better appreciated on the LFB-PA stain. Sections from the gray matter in the basal ganglia show diffuse leukemic infiltrates with surrounding myelin pallor, indicative of myelin loss. Whereas in the white matter, again, there are multiple foci of a perivascular leukemic infiltrate with surrounding myelin pallor, whereas the myelin is preserved in the intervening areas. Similar leukemic infiltrates were also noted in the hippocampus and the pons. Serial sections of the cerebellum show extension of the subarachnoid hemorrhage into the cerebellar folia with multiple tiny petechial hemorrhages. And microscopically, these are confirmed to be perivascular leukemic infiltrates in the molecular layer admixed with fibrin. In the pituitary gland as well, diffuse areas of hemorrhagic infarction were noted secondary to the presence of fibrin thrombi. Therefore, summarizing the findings in the brain, there is subdural and subarachnoid hemorrhage, leukemic infiltrates with associated perivascular myelin loss in the cortex, the corpus callosum, basal ganglia, hippocampus, pons, and cerebellum. There is acute microangiopathy and hemorrhagic infarction in the pituitary. So coming to this organ complex comprising of the liver, gallbladder, pancreas, C-loop of duodenum, and spleen. The liver and the spleen were moderately enlarged. However, no focal or nodular lesions were identified. At a low power, we can see that the lobular architecture of the liver is maintained. However, the portal tracts are expanded by a leukemic infiltrate, which can be seen extending out into the sinusoids. This infiltrate is also seen in a perivenular subendothelial distribution, as well as in the subcapsular location of the liver. These leukemic cells are highlighted on the immunostain for MPO. The background liver shows presence of predominantly microvesicular combined with macrovesicular steatosis, and focally prominence of Kupffer cells is noted in the sinusoidal spaces with focal hemophagocytosis. The splenic red pulp is diffusely expanded by the presence of a leukemic infiltrate, which is highlighted on MPO, and the trabecular veins also show presence of leukostasis. The pancreatic parenchyma did not show any leukemic infiltrates. However, fibrin thrombi were noted in many of the peripancreatic veins, and leukostasis was also seen in the uterine serosal and the paratubal veins.
Dr. Gunjan, please hurry up. Yes,
sir. The esophagus and the stomach showed mild discoloration with presence of submucosal hemorrhages, mucosal erosions, and lymphoid infiltrates. The small intestine showed evidence of acute ischemia with fibrin thrombi in the submucosal veins. And ischemic changes were also noted in the colon. The heart was unremarkable and did not show any leukemic infiltrates. And the thyroid, parathyroid, and adrenal also did not show any leukemic infiltrates. So this is an as yet unpublished experience of our institute with regards to autopsy findings in acute leukemia cases.
Please hurry up.
And of the 11 patients who passed away, they were either therapy naive or had received incomplete induction therapy. And the most common cause of death was found to be malignant infiltration followed by intracranial hemorrhage. Thus, the final autopsy diagnosis in this 26-year-old female with APML, PML RARA positive, is leukemic infiltration in the brain, liver, spleen, lungs, hilar lymph nodes, and right renal sinus fat, with subdural and subarachnoid hemorrhage, leukostasis in the brain, kidneys, lungs, and spleen, DIC involving bilateral kidneys, brain, and lungs, ischemic erosions in the small intestine and trachea, acute tubular injury, diffuse pulmonary hemorrhage with diffuse alveolar damage.